I still don't believe you have pink eye.
I don't either, but
That's just
also
me.
my eye was weird yesterday. There was,
Your mic isn't working.
so
Really?
yeah, but then like I woke up this morning
Yeah,
and
that's
it's
good.
fine.
Oh, that's what you mean.
Well, I already emailed my professor,
Just
so
trying to- trying to talk to her.
the antibiotics started working.
watching Aubrey yet.
Yeah, we can't hear you, so.
That's okay.
And there's no place for me to plug this thing in, so we won't be able to hear you, probably. Actually, let me try something here. Audrey, try talking again.
Hello.
Okay, I can at least hear you on my laptop now. I just had to change the external speaker. Okay, so what do I want to do here? Okay, so today I'm going to talk about the mediastinum or mediastinum. Take your pick. I don't care how you pronounce it. And also the heart. So you've already done most of this dissection, although we're going to continue dissecting into the posterior mediastinum on Thursday. So this should cover us for all of the dissections that you're going to do this week. So as we've discussed before, come on. The mediastinum is basically, you can think of it as a septum, a partition, a wall that lies in the center of the thorax, separating the left and right pleural cavities. So here you see an axial cross section through the thorax, really focusing on the mediastinum, which lies in the middle of the thorax. So you've got the left and right lungs, obviously, sitting in the pleural cavities. And then all of these structures that lie in the midline separating the lungs belong to the mediastinum. And of course, that includes the pericardium and the heart. While you're looking at this picture, though, take a look closely at the lungs. And you might notice that when Netter painted this, he intentionally painted a thin membrane lining the outside of the lung, which would be the visceral pleura. And then he also painted another membrane lining the sides of the mediastinum and then turning to line the inside of the rib cage. So that would be the parietal pleura. So this clearly shows the layers of pleura as well as the mediastinum itself. The mediastinum is subdivided into 4 regions, and there's really not any anatomic significance to these 4 regions. Anatomists like to recognize these 4 regions just because it's convenient to do your dissection one region at a time. So all 4 of these regions are based on where they sit relative to the heart. So the superior mediastinum are all of the mediastinal structures that lie superior to the heart. So from the thoracic aperture, which is the opening that's formed by the first ribs and the manubrium of the sternum and the first thoracic vertebra. So from that aperture down to where the heart begins, all of those structures are in the superior mediastinum, which is shaded in yellow in this particular diagram. Then there's an anterior, middle, and posterior mediastinum. The anterior mediastinum would be the structures that lie anterior to the heart, basically squeezed into that very narrow space between the pericardium and the sternum. The middle mediastinum includes the heart itself, as well as the pericardium and things like the phrenic nerves that are associated with the pericardium. Then the posterior mediastinum includes all of the structures that lie posterior to the heart. So this would include things like the descending aorta, the esophagus, and a few other things. So let's walk through each of these areas one at a time and talk about the structures that are found in each area. And some of this you've already dissected, some of it you haven't. So starting with the superior mediastinum, we see here all of the structures that lie superior to the heart. The heart itself has been removed. So the superior vena cava is cut, the ascending aorta, or the very first part of the aortic arch is cut, and then the pulmonary trunk is cut right there. Excuse me. All of these structures would lie superior to the heart, so this would all be part of superior mediastinum. So, for example, we have some of the large veins that are flowing into the heart. So we've got a left and a right brachiocephalic vein. Each brachiocephalic vein is formed from the junction of the internal jugular vein and the subclavian vein. So, for example, on the right side of the body here, you can see the right brachiocephalic, excuse me, the right internal jugular vein joining with the right subclavian vein together to form the right brachiocephalic. And then on the left side of the body, they're not labeled, but you've got left internal jugular vein and left subclavian vein joining together to form the left brachiocephalic vein. A couple points about these veins. Number one, I think I've already made this point, that you only have one brachiocephalic artery, which is found on the right side of the body, but you do have two brachiocephalic veins. There are separate left and right brachiocephalic veins. Yeah, man.
So is the superior vena cava part of the superior mediastinum, or is that in the middle?
Superior vena cava would be part of superior mediastinum because it actually sits above the level of the heart. So we do have these two brachiocephalic veins, and they do join together to form the superior vena cava. The other thing to notice about the two brachiocephalic veins is how they are asymmetrical. And this is because of the fact that the superior vena cava is flowing into the right side of the heart, into the right atrium. The superior vena cava is shifted a bit towards the right side of the body. So that means that the right brachiocephalic vein is shorter because it doesn't have to travel as far to reach the superior vena cava. It's also oriented more vertically, and I think you can tell from the picture how that right brachiocephalic vein is almost straight up and down. It's much more vertical. The left brachiocephalic vein, on the other hand, has to be a lot longer because it has to cross from the left side of the body over to the right side to reach the superior vena cava. It's also oriented at much more of a horizontal angle because of the fact that it is crossing from the left side to the right side before flowing into the superior vena cava. So if you ever, for any reason, if you ever had to illustrate these brachiocephalic veins as they join together to form superior vena cava, just make sure you make note of that asymmetry. So then we've got the aorta itself. Whoops. Jumped ahead on me. You've got the aorta itself, the aortic arch, with its three branches that we've already talked about many times. Brachiocephalic artery found only on the right, then the left common carotid, and then finally the left subclavian artery branching off the aortic arch. You can also see the left vagus nerve here. The right vagus is a lot harder to see, but you should have all seen the left vagus nerve yesterday in your dissections in this area, how it crosses the aortic arch. And just as it's crossing the aortic arch, it gives off a branch, which is the left recurrent laryngeal nerve, which is going to loop around the aortic arch and then travel all the way back up the neck, up to the larynx, where it innervates most of the muscles that move the vocal cords. The right vagus does the same thing. The right vagus gives off a right recurrent laryngeal nerve, but that's looping around the right subclavian artery. So it's just not visible in this particular section, in this particular image. Other structures that you find in the superior mediastinum would be the trachea, of course, that's making its way down into the thorax and eventually bifurcating. And then the esophagus, which you can't see here, but the esophagus would be sitting just posterior to the trachea, also descending from the neck down through the superior mediastinum and eventually all the way through the mediastinum down to the diaphragm. Now, in this particular picture here, we're attempting to look at both the anterior and middle mediastinum, but there's really almost nothing in the anterior mediastinum. Most of what's in the anterior mediastinum is just a little bit of fat and loose connective tissue that connects the pericardium to the inside of the sternum. The only structure of any significance in the anterior mediastinum is the thymus. The thymus is a gland that's responsible for the production of all of your T cells. In fact, that's where T cells get their name. The T stands for thymus. So all of your body's T cells are produced in the thymus. But it deteriorates with age pretty significantly. So in a much younger person, somebody much younger than our cadavers, you'd probably be able to actually identify it fairly clearly. But in most of the cadavers, by the time they reach that age, it's atrophied so much that it's virtually indistinguishable from the fat. So I suspect most of you have already just completely removed it without realizing it, because it was whatever was left of it looked like just part of the fat that you removed. Then the middle mediastinum includes the heart, which is in the pericardium, and things like the phrenic nerves, and the small vessels that run with the phrenic nerves, which I didn't label on here, the pericardiaco-phrenic artery and vein that travel with the phrenic nerves. We'll come back and talk about the heart in a lot more detail separately. But basically, this is the entire anterior and middle mediastinum shown right here. So then the last part of the mediastinum is the posterior mediastinum. So these are the structures that lie posterior to the heart. So the trachea, obviously, it's going to pass through the superior mediastinum and continue down into this posterior mediastinum behind the heart. This is where you find the bifurcation of the trachea into the left main bronchus and the right main bronchus. The esophagus also continues down through the posterior mediastinum, eventually passing through the diaphragm to feed into the stomach. And the descending aorta, or sometimes called thoracic aorta, which is continuing from the aortic arch down through the posterior mediastinum, also eventually passing through the diaphragm into the abdomen. So those are the main structures in the posterior mediastinum. Couple things that aren't visible here. There's something called the thoracic duct, which you might recall from earlier in the semester. I think it was on the previous exam we talked about this. Thoracic duct is one of those lymphatic vessels that drains into the subclavian vein on the left. And it's actually bringing all of the lymphatic fluid from the entire abdomen and both lower limbs, and it travels up through the mediastinum. So in your dissection on Thursday, you'll actually move the esophagus out of the way and look way back in the posterior mediastinum, right on the vertebral bodies of the thoracic vertebrae. And hopefully you'll find this tiny, thin little duct back there, which would be the thoracic duct. The two vagus nerves are also traveling through the posterior mediastinum. So after the vagus nerves give off their recurrent laryngeal nerves, the vagus nerves are going to continue. They're actually going to travel with the esophagus, eventually piercing through the diaphragm to provide parasympathetic innervation to all of the abdominal organs. The left vagus is visible here. You can see it higher up as it's crossing the aortic arch and right where it gives off the recurrent laryngeal nerve. And then after that, the left vagus ends up lying on the anterior surface of the esophagus. And it's sometimes called the anterior esophageal plexus. But it's really just vagus nerve that sits on the front of the esophagus. The right vagus, on the other hand, crosses the right subclavian artery and also gives off a recurrent laryngeal nerve. Then the right vagus kind of disappears from view because it ends up on the posterior surface of the esophagus. Now, this is a consequence of the rotation of the organs in the abdomen, that as the abdominal organs rotate, the esophagus also kind of twists in place. So earlier in embryonic development, the left vagus really is on the left side of the esophagus, and the right vagus is on the right side of the esophagus. But as the esophagus twists to the right, the left vagus comes to lie in front, and the right vagus ends up lying in back of the esophagus. We've already talked a lot about the arteries in the thorax, but let's just review them here. So some of the arteries that lie in the superior mediastinum would include the aortic arch itself and its three major branches, so brachiocephalic, left common carotid, and left subclavian arteries. And then all of the posterior intercostal arteries. that are branching directly off the aorta and traveling through the intercostal spaces. Something I should point out about the intercostal arteries, if I didn't make this point before, that since the aorta is shifted towards the left side of the body, the posterior intercostal vessels are shorter on the left side and considerably longer on the right side, because on the right, they actually have to cross all the way across the thoracic vertebral bodies before actually reaching the intercostal spaces on the right side. Now, you know that in most of this course, we haven't paid a whole lot of attention to veins, but here in the thorax, we're going to pay a lot more attention to veins. Same thing in the abdomen. The reason for that is that in the thorax and in the abdomen, there are a lot of unique veins that don't have any artery equivalents. You know, normally we've skipped over the veins because you just assume that for every artery, there's an equivalent vein running with it. So we just kind of removed them and didn't worry about them. But here we have a lot of veins that either have a very different branching pattern or in some cases don't have any artery equivalents at all. So, for example, we've already talked about the brachiocephalics, but let's just go over those again real quick. So, right internal jugular and right subclavian join to form right brachiocephalic. Left internal jugular and left subclavian join to form the left brachiocephalic vein. Those are asymmetrical, with the right one being shorter and more vertical, the left one being longer and more horizontal. The two brachiocephalic veins then join to form the superior vena cava, which would be flowing directly into the right atrium of the heart. There are a bunch of other veins shown here that don't really have any artery equivalents, and these are the azygous veins. So remember that the intercostal arteries are branches directly off of the aorta. But there's no large vein in the thorax that's comparable to the aorta. So the intercostal veins, which are draining the deoxygenated blood from the intercostal spaces, they're actually flowing into a different system of veins before ultimately returning to the heart. So on the right side of the body, all of the intercostal veins are collected by something called the azygous vein. The azygous vein runs right along the vertebral bodies and eventually turns anteriorly. So it's turning towards the front of the body and is actually going to join with the superior vena cava. So I'll try to use the pointer here so that the Zoom folks can see this. So you've got all of your intercostal veins on the right side flowing into this vertical azygous vein, which is running right along the vertebral bodies of the thoracic vertebrae. And then right here is where the azygous vein is turning anteriorly, turning towards us in this particular view, to flow into the superior vena cava. So all of the deoxygenated blood from all the intercostal spaces on the right are flowing into that azygous vein and then eventually back into the superior vena cava. On the left side, the situation is similar, but not exactly the same, not exactly a mirror image. As a matter of fact, the word azygous means not identical or not like a mirror image. Zygous means like twin, I think. And anytime you put an A in front of anything in a Latin word, it means not. So not twin, not identical. And it's referring to the fact that the left and right sides are different. So over on the left side of the thorax, the intercostal veins are all flowing into two different veins known as hemiazygous veins. More inferiorly, there's something called just simply hemiazygous vein. And then more superiorly, there's something known as the accessory hemiazygous vein. Now, in some ways, these do look like they're a mirror image of the azygous vein on the right, but it turns out that the azygous vein on the right is much, much larger than either the hemiazygous or accessory hemiazygous veins. The reason for that is that the hemiazygous vein and the accessory hemiazygous vein, which we see here on the left side of the body, those are not able to flow directly into the superior vena cava because the superior vena cava is over on the right side of the body. So there's no direct route for the hemiazygous or accessory hemiazygous to flow into the superior vena cava. Instead, what happens is that the hemiazygous vein and the accessory hemiazygous vein actually flow across. They have little connections that flow across the vertebral bodies behind the esophagus, and the blood flows from left to right from the hemiazygous veins across into the azygous vein. So ultimately, most of the blood in the hemiazygous veins on the left is flowing across the midline from left to right over to the azygous vein on the right. So the azygous vein is collecting not only all of the blood from the intercostal spaces on the right, but indirectly, it's also collecting all the blood from the intercostal spaces on the left, but because of these connections flowing from the hemiazygous veins across from the left to the right sides. Okay, some nerves in this area, most of which we've already talked about. So we've got the vagus nerves. Again, the left vagus is going to come down and cross the aortic arch, where it's going to give off the left recurrent laryngeal nerve, which will then travel back up through the neck up to the larynx. And then the left vagus ends up lying on the anterior surface of the esophagus before passing into the abdomen. Right vagus has a similar course, a little bit different though, because it's going to cross the right subclavian artery, and it's going to give off the right recurrent laryngeal nerve, which loops around the subclavian artery. And then the right vagus nerve is going to kind of disappear from view because it ends up sitting on the posterior surface of the esophagus. Now, the other thing that's shown on here that we haven't really talked about much, but we'll come back and talk about this in a lot of detail on Thursday, are the sympathetic trunks. Yeah, Brianna. All these little balls, these little lumps? Yep, that's what I was just about to talk about. So those belong to the sympathetic trunk, or sometimes called the sympathetic chain, because it consists of a chain of ganglia that are all joined together. So the only time that we've seen or really talked about the sympathetic nervous system in here so far in this class is when we were dissecting the pharynx. I pointed out something called the superior cervical sympathetic ganglion, which is a great big ganglion that sits at the upper end of the sympathetic chain. But here in the thorax, especially on Thursday, when you're dissecting into the posterior mediastinum, you're going to go looking for the sympathetic chain here in the thorax. So as you just pointed out, Brianna, it's a series of sympathetic ganglia that are all joined together to form a continuous chain running down both sides of the thorax. Just a little bit lateral to the vertebral bodies in the posterior part of the mediastinum. And if you look very closely at the image, there are actually little connections between each one of these sympathetic ganglia in the thorax and the intercostal nerves. At every single level, every single vertebral level on both the left and right, there are little connections between the sympathetic chain, between the ganglia and the intercostal nerves. We'll come back on Thursday and talk in a lot more detail about what those little connections are and what they do. So looking into the right side of the body, here's what all of the structures in the mediastinum are going to look like. So we've got superior mediastinum way up here, superior to the heart. Got anterior mediastinum sandwiched in between the heart and the sternum. So I think the thymus is just barely visible right there. It's not labeled, but otherwise it's just a little bit of loose connective tissue. We've got the heart itself sitting within the pericardium with the phrenic nerves running along the pericardium, along with the pericardiaco-phrenic artery and vein. We've got superior vena cava here flowing down into the right atrium of the heart. And here you see that azygous vein which is found only on the right side of the body, coming up along the thoracic vertebrae and then turning anteriorly to flow into the superior vena cava. And then you see that sympathetic chain or sympathetic trunk back here, just lateral to the vertebral bodies, right about where the vertebrae are joining the ribs. Just a chain of these ganglia all strung together. And then you can just barely see esophagus and trachea up there in the superior part of the mediastinum. And then similar kind of view looking in from the left side, the big difference here, of course, being the presence of the aorta on the left. So we've got the aortic arch with its branches up here in the superior mediastinum, and then the aorta turning to become the thoracic aorta or descending aorta, heading down to eventually pierce through the diaphragm. All right, so let's turn our attention now to the heart. And before we get into the details of the heart itself, let's just refresh our memories about the pattern of blood flow as it flows through the heart. So if you look closely at this picture, you'll see that the different steps in the process are numbered in order. So there's a number 1, which is an arrow pointing down through the superior vena cava. There's also a number 1 pointing up through the inferior vena cava in the bottom left corner of the image. So this represents all of the deoxygenated blood from the whole body. All of the deoxygenated blood from the upper part of the body, so the head, the neck, the upper limbs, and the thorax, is all flowing through the superior vena cava into the right atrium of the heart. All the blood from the lower part of the body, so the abdomen, pelvic cavity, and lower limbs, is all flowing up through the inferior vena cava into the right atrium. So the right atrium of the heart is labeled number 2. So that right atrium fills up with deoxygenated blood from the entire body. And when it's full, the muscles in the wall of the right atrium contract and push the blood through what's called the right atrioventricular valve. Atrioventricular just meaning, between the atrium and the ventricle. So there's a right atrioventricular valve, sometimes called the tricuspid valve. The blood flows from the right atrium into the right ventricle, labeled number 3. The ventricle is just a large muscular pouch. When the ventricle fills up with blood, it's also going to then contract, and it's going to push the blood up from the right ventricle up into the pulmonary trunk. The pulmonary trunk is then going to split into a left pulmonary artery to the left lung, and a right pulmonary artery going to the right lung. Those are labeled number 4 on the slide. That blood then becomes oxygenated by passing through little capillary beds on the alveoli. And the oxygenated blood then returns to the heart through a set of 4 pulmonary veins. There are 2 pulmonary veins on the left and 2 pulmonary veins on the right. These are all labeled number 5 on the slide. These flow into the left atrium, labeled number 6. Left atrium is also just a thin muscular bag. When it fills up with blood, it's going to contract to push the blood down into the left ventricle, labeled number 7. And left ventricle is a very, very strong muscular pouch, which is then going to contract and force the blood up into the aorta, labeled number 8. And from the aorta, some of the blood is going to flow out through the branches off of the aortic arch, so brachiocephalic, left common carotid, and left subclavian. But then some of the blood in the aorta is also then going to flow down through the descending aorta, down through the thorax, giving off intercostal vessels, and then eventually down into the abdomen and lower limbs. So make sure you clearly know the pathway of blood through the heart and through the lungs. So you've already done this part of the dissection. You've already looked at the heart in situ, as it sits in the thorax, and you've gone ahead and removed it. I assume that the book probably, or the dissector manual probably asked you to, make note of certain things before you moved ahead with removing it. One of the most important things to notice about the heart as it sits in its normal position within the thorax is that the heart itself is rotated to the left. So If the heart wasn't rotated, you would see equal amounts of the left ventricle and the right ventricle, and equal amounts of the left atrium and the right atrium. But the heart has rotated or twisted to the left side, so that as you look at the heart sitting in the chest, most of what you're seeing is right ventricle. You're seeing much less of the left ventricle, and you're seeing essentially none of the left atrium. The left atrium has rotated all the way around towards the posterior surface of the heart. And in fact, it's actually the left atrium that makes up most of the posterior surface of the heart. So in this anterior view, you're seeing right atrium, abbreviated RA, and a lot of right ventricle, RV, just a little bit of left ventricle and none of the left atrium at all. On the other hand, if you look at the posterior aspect of the heart, and this is what the heart would look like in a straight posterior view, you see that the posterior surface of that heart is dominated by left atrium. So here we're looking at the left atrium, makes up most of the back of the heart, with the two pulmonary veins entering from the left lung on the left side, two pulmonary veins coming from the right lung on the right side, both draining into the left atrium. You can see the aorta, which is essentially coming towards us in this view because the aorta turns posteriorly. The aortic arch is turning posteriorly, so it's kind of coming at us in this view. We've got the pulmonary trunk splitting into left and right pulmonary arteries, bringing deoxygenated blood to the left and right lungs. You've got superior and inferior vena cava, and Netter has painted this pretty well, that as the heart sits in its normal position in the body, the superior and inferior vena cava should line up vertically with one another. They shouldn't be offset. You shouldn't have one, shifted to the right and another one shifted more to the left. The two vena cava should actually line up perfectly in a vertical line. That'll help you orient the heart as you pick it up and move it around. If you keep, in fact, what I do sometimes is I'll actually stick a probe through the superior and inferior vena cava right through the right atrium. And if I keep that probe vertical, it helps me to orient the heart in its proper position as I handle it and look at it. It's also an important thing to keep in mind when you're illustrating the heart, is to show the two vena cavae actually in line with one another. Also shown here is the coronary sinus, which we'll come back and talk about more in a minute. But this is the large vein of the heart, where all of the smaller cardiac veins that are bringing deoxygenated blood back from the heart muscle itself, all of that deoxygenated blood from the heart itself is gathered by that coronary sinus, which then drains into the right atrium. So the right atrium is receiving blood not only from the superior and inferior vena cava, but the right atrium is also receiving blood from the coronary sinus, which is deoxygenated blood from the heart muscle itself. All right, so one of the main things you did in lab yesterday was to dissect the coronary arteries. And often this meant you had to dig some of the fat out of the surface of the heart to be able to trace these arteries. Yeah. Coronary sinus drains into the right atrium. Okay, so there are two main coronary arteries that are branching directly off of the aorta. And then each of those gives rise to further branches. So this particular slide is looking only at the left coronary artery, which is branching off the left side of the aorta. And by the way, just to help orient you what we're looking at here, this is basically an anterior view of the heart. Most of what you're seeing here would be right ventricle. Over here on the far left side of the slide is the right atrium, and there's a little hook there that is reflecting the auricle of the right atrium out of the way. And students are sometimes confused by what these rounded bumps are right here. Those are the cusps of the aortic valve. So the blood that travels up into the aorta is coming from the left ventricle. So the left ventricle is not really visible here. It's kind of hidden because it's more in the back of the heart. But blood from that left ventricle would push through these three semicircular cusps of the aortic valve and then push its way up into the aorta. The two coronary arteries originate immediately superior to those semicircular cusps of the aortic valve. In fact, I don't recall if the book has you do this or not, but one thing you can do with your heart is you could actually take a probe and push the probe down into the aorta, and you may be able to get the tip of the probe to actually go into the openings to both the left and right coronary arteries. Okay, so here we're looking just at the left coronary artery. It's going to branch off just above the left cusp of the aortic valve. And the left coronary artery itself is fairly short. It's typically an inch or less in length. And very quickly, it's going to split into two branches. One of those branches is going to wrap around towards the front of the heart, and it's going to lie in the groove between the left and right ventricles, called the interventricular groove. So this is known as the anterior interventricular artery. It's anterior because it's lying on the front of the heart, and interventricular because it lies in that groove between the left and right ventricles. I think I mentioned in an earlier class that cardiac surgeons have different names for a lot of these vessels. And here's another good example of that. What anatomists call the anterior interventricular artery, a heart surgeon would call the left anterior descending, which makes sense. Left because it's originating from the left coronary artery, anterior because it's on the front, and descending because it's bringing blood down, sort of descending along the front of the heart. I'm not going to test you on those alternate names, but I'm putting them in there just because they think these are things that you should probably be familiar with. So this anterior interventricular artery is one of the branches of the left coronary artery. The other large branch is a circumflex branch, which is going to wrap around towards the back side of the heart to supply the posterior part primarily of the left ventricle. The other main coronary artery is the right coronary artery. Once again, you see those little lumps in there, which represent the cusps of the aortic valve. The right coronary artery originates from the aorta, just above the right cusp. Yeah, Raven?
Are we able to use either names?
Yeah, you can use the other names if you want. You can use them interchangeably. But I'm not going to, expect you to know the heart surgeon names specifically. Okay, so right coronary artery originating from the aorta, just above the right cusp of the aortic valve. It's going to lie in the groove between the right atrium and the right ventricle. So this is what's known as the coronary sulcus, or the atrioventricular sulcus. It's just this indentation between the right atrium and the right ventricle. So right coronary artery is lying in that coronary sulcus, or atrioventricular sulcus. And when it reaches the sort of bottom right-hand edge of the heart, it gives off a branch called the right marginal branch. It's called right marginal branch because oftentimes this edge of the heart, which is resting on the diaphragm, is sometimes referred to as the margin of the heart. So it's coming off the right coronary and it's sitting on the margin, so it's right marginal branch. And then the rest of the right coronary artery is going to wrap around the back of the heart and lie in the interventricular groove on the posterior aspect of the heart, where it's called the posterior interventricular artery. So it's posterior, of course, because it's on the back of the heart, and interventricular because it lies in that interventricular groove between left and right ventricles. This is another one that has a different name among heart surgeons. Instead of posterior interventricular artery, they would call it the posterior descending artery, or PDA. Interesting thing about this posterior descending artery, the textbook situation is that PDA, or posterior interventricular artery, is originating primarily from the right coronary artery. But there are also situations where the posterior interventricular artery is actually originating from the circumflex branch instead, coming from the left side. So there is a fair amount of variation in the arteries of the heart, including something as big as the posterior interventricular can have different origins, just depending on the individual. But I think this is the more common situation. Yeah. Yeah.
You said the right coronary artery lies in the coronary sulcus.
Yep.
Did you use that word interchangeably with intraventricular sulcus?
No, atrioventricular sulcus.
Atrial.
Yeah, right. That's important distinction. There's an interventricular sulcus, means between the two ventricles. But there's also atrioventricular sulcus, which is the groove that lies between the atrium and the ventricle on both the left and right sides of the heart. So sorry, yeah, I may not have enunciated that very clearly.
Yeah, it's just confusing. Wait, so.
Oh.
And atrioventricular sulcus is interchangeable with coronary?
Yes.
Okay.
Yeah, atrioventricular sulcus is the same thing as coronary sulcus.
We have to know both words.
No.
Okay.
If you know one, I'll be happy. Okay, so here we see a posterior view of the heart, and we can now see some of those coronary arteries as they come around the back of the heart. So here's the circumflex branch, which is derived from the left coronary artery, wrapping around onto the posterior surface of the heart. There's that right marginal branch running right along the right-hand edge, or that margin of the heart. And then we see posterior interventricular artery also coming from the right coronary artery. But as I said before, there's some variation in that posterior interventricular artery, that sometimes instead of coming from the right coronary artery over here, it may actually be a continuation of the circumflex branch coming from the left coronary artery instead. Also shown on here are some of the veins of the heart. And I know some of you were actually trying to identify all of these and identify the names yesterday, but I'll tell you right now, the only vein that I'm going to expect you to be able to identify on the lab exam, the only one I expect you to know about in the on the lecture exam, would be just the coronary sinus itself. So all of the other veins of the heart, the great cardiac vein, the middle cardiac vein, the small cardiac vein, those are all flowing into this coronary sinus. And then the blood in the coronary sinus is flowing towards the right, eventually draining through a little valve into the right atrium of the heart.
So you just need to know about the coronary sinus.
Just coronary sinus, yeah, as far as veins go on the heart. All right, so today in lab, you're going to look at the interior of the heart. You're going to cut open all four chambers of the heart and look inside. You're not going to cut them open like this, though. I don't want you to just completely slice the heart in half. But I put this slide in here because it's the only view where you're going to actually see the interior of all four chambers simultaneously. And it's really important that you look at that little orientation drawing down in the bottom right corner, because this shows what that plane of cross-section looks like. In order to cut into the heart in such a way that you can actually see all four chambers, you can't just do a straight coronal section. I think a lot of people assume that when you see a cut section of the heart, you're looking at it sliced in a coronal plane, which would be, you know, this vertical plane that's parallel to the front of the body. But in order to get that cross-sectional view, the plane of section has to sit at quite an angle, which you can see that Netter has illustrated. It looks like a sheet of glass cutting the heart in half. So the heart is actually kind of sitting at this angle. The apex of the heart, which is the pointy tip of the heart down here, formed by primarily by the tip of the left ventricle. That pointy end of the heart is pointing kind of down towards the left. And so the plane of cross-section has to be parallel to the orientation of the way the heart sits in the body. So just so you're aware that this is not a true coronal section. But looking at this oblique cut section here, you can see a little bit of the interior of the right atrium. You see the inside of the right ventricle, and you actually see the atrioventricular valve that connects the atrium to the ventricle. And then on the left side, you can see a little into the left atrium, and then likewise into the left ventricle with the left atrioventricular valve. And then up here, you see just a little bit of the aortic valve, like 1.5 cusps of the aortic valve cut in cross section. So when you do your dissection in lab today, you're going to be cutting into the 4 chambers of the heart, 1 chamber at a time. You're going to start with the right atrium. And students get confused by the instructions in the dissector. That's not a reflection on the students. That's more a reflection on the badly worded instructions in the dissector. But I'll try to describe for you here what I want you to do. I mean, I'm going to say basically the same thing that the dissector says, but hopefully I'm going to say it in a way that's clearer, I hope. So you're going to actually start with the auricle of the right atrium, which is that lumpy little flap that kind of hangs off the atrium. And you can actually tell that it is hollow inside, so it is part of the atrium itself. But you're going to take a pair of scissors, and you're going to start up there at the auricle and make a little snip into the auricle. And then you're going to carry that cut posteriorly from the auricle back towards the superior vena cava. And you want to go as far back in the right atrium as you possibly can without actually, cutting into the other atrium. So notice the 2 pulmonary veins back there that are flowing into the left atrium. You want to cut almost all the way back to those pulmonary veins so that you're cutting back, like into where the superior vena cava flows in. And then you're going to carry that cut inferiorly, just in front of the 2 pulmonary veins, all the way down towards the inferior vena cava. And then you're going to take your scissors and you're going to turn the cut back towards the front, cutting from right to left, back across the bottom of the atrium. The reason that it's so important to cut really far back into the atrium here, all the way back almost to the other atrium, is that we want to see this thing called the crista terminalis. And if you carry the cut just partway back into the atrium and then cut vertically a little too far anteriorly, you're going to leave that crista terminalis behind, and you won't actually be able to see it in this little flap, this little door that we open up and reflect open. So you can tell from this illustration that the atrium itself is really just a big hollow chamber. But the inside of that hollow chamber is lined with these little bands of muscle called pectinate muscles. These are the muscles that are actually responsible for contracting to compress the atrium to force the blood from the right atrium ultimately down into the right ventricle. This thing called the crista terminalis that I want you to be able to see is simply where all of those pectinate muscles kind of converge and join together to form this very thick muscular ridge. So the crista terminalis literally means the crest at the end, the terminal crest or the ridge at the end. And it's simply where all of those pectinate muscles join together to form this large muscular ridge. In a few minutes, we'll see that the inside of the ventricles also has muscular bands on the inner surface, but the texture and the pattern of the muscle bands on the inside of the ventricle is very different. And so there's a completely different name for the texture of muscle fibers that you see in the ventricles versus the atria. So these pectinate muscles, it's referring to the muscles themselves, but it's also referring to this distinctive pattern, how you have these thin, more or less parallel little bands of muscle all converging on that crista terminalis. Okay, so pectinate muscles are found only in the atria. You'll find them in the left atrium also. The left atrium does not have a crista terminalis, only the right atrium. Yeah, but,
Do you need to know what innervates these?
sort of. Zoom people, and Ben just asked if we need to know what innervates these. Thursday, we're going to talk about the autonomic nervous system, which is what controls the heart rate, either elevates or depresses the heart rate. So ultimately, the contraction of the heart and the innervation of these individual muscles is all regulated by the sympathetic and parasympathetic components of the autonomic nervous system. Right, so when you cut into the right atrium, you reflect that big flap over, you'll see this pattern of pectinate muscles and that crista terminalis, hopefully. There'll probably be a lot of blood in the right atrium, a lot of blood clot. So you want to remove that, and feel free to rinse it in the sink if you need to. Just make sure the little traps are in the sink so all that blood doesn't go down and cause a clog in the sink. And what you're going to want to then look for are some of these other features inside the right atrium. So you've got superior vena cava flowing down into the right atrium, so you should be able to easily find the orifice of the superior vena cava. What may be a little trickier to find is that there's actually a little tiny flap of tissue that creates a valve that allows blood to only flow one way from the superior vena cava into the atrium. When the atrium contracts, though, you don't want the blood to just flow backwards into the superior vena cava. So there's just this thin little flap of tissue that forms a valve to prevent blood from flowing backwards. Same thing with inferior vena cava. You should be able to see the orifice of inferior vena cava. And right here, you can actually see the valve of the inferior vena cava. So there's a similar one on superior vena cava as well. Just a thin little fold of tissue that would cover the orifice of the inferior vena cava to prevent blood from flowing backwards when the atrium contracts. And then finally, there's a little hole right here, just a little bit medial to where the inferior vena cava enters. This is the orifice for the coronary sinus. Remember, that's the big vein on the back of the heart that collects all the deoxygenated blood from the heart itself. So that is flowing into the right atrium as well. And that also has its own little flap, its own little valve, so that blood can't flow backwards into the coronary sinus. When the right atrium does contract, since the blood is not able to flow backwards through the superior or inferior vena cava or into the coronary sinus because of those little valves, the blood can really only go one place. It's going to push open the flaps of the right atrioventricular valve, and the blood is going to get pushed from the atrium into the right ventricle. And we'll look at that valve in more detail in a minute when we actually look into the ventricle. The other feature I want to point out here in the right atrium is this thing called the fossa ovalis. It's this shallow oval-shaped indentation on the medial wall or inner wall of the right atrium. That's a remnant of the foramen ovale, which was an actual opening in the septum that separates the left and right atria from one another. So in the fetus, because all of the oxygenated blood is coming in through the umbilical cord, the oxygenated blood in the fetus is actually entering the right side of the baby's heart, as opposed to the left, since the baby's lungs aren't doing anything when it's in utero. So all that oxygenated blood is coming into the right atrium. You need a way to get that oxygenated blood from the right side over to the left side of the heart. So there are actually connections between the right and left sides that allow that oxygenated blood to flow from the right side directly to the left side. So in the fetus, there was actually an opening where this little fossa is located now, and it was called the foramen ovale, which you've heard that term before. It just means oval hole or oval window. And right around the time of birth, that foramen ovale is supposed to seal shut, and the little membrane is supposed to form in there to close it off, and that's called the fossa ovalis now. So just a little remnant of that old foramen from the fetus. And of course, sometimes it doesn't close, and you get blue babies that aren't getting sufficient oxygen. Okay, so after you've finished dissecting the right atrium, then you're going to dissect the right ventricle. And this is a fairly tricky dissection to do. What you want to do is you want to start cutting down near the right margin of the heart, so the bottom right-hand edge of the heart. And you want to cut superiorly. You can use either a scalpel or a pair of scissors. You might have to start it with a scalpel, but I recommend you switch to a pair of scissors because you're less likely to damage the interior structures. You want to cut vertically right adjacent to the right coronary artery. So that right coronary artery is going to be sitting in this sulcus over here between the atrium and ventricle. So you want to try to cut just anterior to that right coronary artery. And you're going to cut all the way up until you reach the pulmonary valve, which is a little valve with 3 cusps that regulates the flow of blood into the pulmonary trunk. So you're going to cut all the way up towards the pulmonary valve. Then you're going to cut across anterior to the pulmonary valve, and then carry that cut back down right along the septum between the 2 ventricles. That's the interventricular septum. Carry that cut all the way back down to the right margin of the heart. So what that's going to do is it's going to create a big flap that's almost like a big upside down V. And you're going to fold that flap down. That's going to represent basically the whole anterior wall of the ventricle, which has been flipped down out of the way to allow you to see into the right ventricle. And when you do that, you're going to notice that the inside of the ventricle has a distinctive texture of muscle fibers. But this texture is quite different than what it was in the atrium. So in the atrium, we had more or less parallel, kind of skinny fibers that were more or less parallel to one another, and we called those pectinate muscles. Here in the ventricle, the little bands of muscle, first of all, are typically a lot thicker, and they also crisscross a lot more. They're not all parallel to one another. It almost looks like a wicker basket that's been woven with this sort of interwoven pattern of crisscrossing muscle fibers in the ventricle. This is what's known as the trabeculae carnae, which literally translated means meat bars or meat ridges. It looks very different from the pectinate muscle texture, and it gets this different name. All right, so then inside the ventricle, we're going to see the right atrioventricular valve. Looks kind of like a parachute to me, with lots of little strings, hanging off the parachute. The right atrioventricular valve is sometimes called the tricuspid valve because it has 3 cusps, also known as leaflets. So 3 leaflets, also just called flaps, the 3 distinct flaps or cusps of this valve. Each of those cusps or leaflets of this tricuspid valve or right atrioventricular valve is then connected to a set of muscles known as papillary muscles. And there are these little tendinous cords that are connecting each cusp of the tricuspid valve or right atrioventricular valve, connecting those cusps to these papillary muscles. These little tendinous cords are called the chordae tendineae, which literally means the tendinous cords. These are like the little strings of the parachute. So those chordae tendineae are connecting the cusps of the valves to a set of papillary muscles. So you can think of the papillary muscles as being the skydiver, the person, suspended from the little parachute cords here. Those papillary muscles are actually attached to the inner surface of the ventricle itself. In fact, they're almost like outgrowths of that trabeculae carnae structure of the muscular wall of the ventricle. And they are muscles. They do contract just like any other muscle. And I think a lot of people have misconceptions about what these papillary muscles do. Because if you think about it, right, we've got a muscle that is connected by these chordae tendineae to the cusps of the valve. So you might assume that when the muscles contract, when the papillary muscles contract, they pull open the cusps of the valves, which seems to make sense, but it's not actually what happens. So I think there's a perception that you need these papillary muscles to open the cusps of the valves in order to allow blood to flow from the right atrium into the right ventricle. But turns out the blood flows easily from the right atrium into the right ventricle simply because the right atrium is contracting. So there's increased pressure in the right atrium as the atrium contracts. So the blood simply pushes the valves open. So the valves don't need to be opened by these muscles. So then people think, well, okay, if the papillary muscles aren't opening the valves, maybe they're responsible for closing the valves somehow. And turns out that's not the case either. The thing that closes the valves is as the entire ventricle itself begins to contract, the pressure of the blood in the ventricle is enough to simply push those flaps back so they close and seal on their own. So it's the increase in pressure in the ventricle as the pressure begins to contract that is actually responsible for closing those valves. So what the heck do the papillary muscles do? Really, their only function is to simply anchor the cusps of the valves so that when the pressure really increases in the ventricle as the ventricle contracts, you don't want these cusps to actually turn backwards and invert into the atrium and allow the blood to just go rushing back into the atrium. So they're simply there to kind of hang on to the cusps of the valves, or to anchor the cusp of the valves so that they can't turn backwards and just allow the blood to flow backwards into the atrium. So there are three separate cusps to this right atrioventricular valve. That's why it's sometimes called the tricuspid valve. And each cusp is attached to its own set of papillary muscles. So the most obvious one in this picture there's a great big cusp here in the front of the valve connected by a series of chordae tendineae to these two papillary muscles right here. These would be known as the anterior papillary muscles because they're connected to the anterior cusp of that atrioventricular valve. Then if you look very closely, kind of hidden way back inside the ventricle, you see the tips of two other papillary muscles back there that are connected to the posterior cusp of the right atrioventricular valve or tricuspid valve. And then the final cusp, the third cusp of the tricuspid valve, is really tiny. It's right up here. And it's connected by chordae tendineae to this little tiny papillary muscle that's actually originating from the interventricular septum. This is what's known as the septal cusp of the tricuspid valve or right atrioventricular valve, because the papillary muscle is actually originating from the interventricular septum. Okay, so we've got a group of anterior papillary muscles attached to the anterior cusp, posterior papillary muscles attached to posterior cusp, and then a tiny septal papillary muscle attached to the very tiny septal cusp of the tricuspid valve. When the wall of the ventricle contracts and all of that blood is then forced under pressure, the atrioventricular valve closes, so the blood can't go back into the atrium. Instead, the blood flows superiorly up through the pulmonary valve. That pulmonary valve has three little semicircular cusps. It looks exactly the same as the aortic valve. It pushes those three little semicircles open, and the blood is able to then flow up into the pulmonary trunk and eventually out to the left and right lungs. One other thing I want to point out here, which I think you'll be able to see in lab, is something called the marginal trabecula. This is a very important band of muscle. And it gets its name from the fact that it connects the septum, the interventricular septum between the two ventricles, to the margin, which would be the right margin, that lower right-hand edge of the heart. So it's connecting the septum to the right margin. And typically it's also connecting to the anterior papillary muscles, which is what Netter is shown here. So this little band of muscle running from the interventricular septum over to the anterior papillary muscles and eventually connecting to the margin of the heart over here. It's important because part of the conducting system of the heart is located in there. And one of these days I should probably add a slide about the conducting system because it's something that you should probably all know, but I don't think I have one in here. The conducting system refers to the group of pacemaker cells in the heart that actually generate the electrical signals that actually cause the contraction of the different heart muscles. So actually, Ben, that kind of gets to your question about what innervates the heart. The sympathetic and parasympathetic nervous systems control the rate of the heart, the rate of the heartbeat, but all they're doing is they're simply stimulating the heart's own electrical system to either increase or decrease the heart rate. The actual signals that control the beating of the heart muscle are generated by these clusters of cells within the heart itself. So there's something called the sinuatrial node, which is just a group of pacemaker cells that actually generate the signal that makes the upper part of the heart contract. That then stimulates what's known as an atrioventricular node, which then has little fibers that continue into the ventricles and stimulate the ventricles to contract. So there's a set of electrical fibers. I mean, they're kind of like nerves, but not exactly. A set of these conducting fibers of the heart that run right through the interventricular septum. These are called the left and right bundle branches. And then the right bundle branch actually travels through that septomarginal trabecula over to the right margin of the heart. So anything that injures that septomarginal trabecula can actually sever the right bundle branch and completely prevent contraction of most of the muscle of the right ventricle. So if someone has a heart attack that injures that part of the heart muscle, it can really have devastating consequences because then you basically lose the ability for the whole right ventricle to beat. All right, jumping over to the left side of the heart, I don't have pictures to show you exactly how you're going to do these dissection steps. The next thing you'll dissect would be the left atrium. You're going to want to approach the left atrium from the back of the heart. Basically, what you're going to do is you're going to make a small upside down U-shaped cut in the posterior wall of the left atrium between the four pulmonary veins on the back of the atrium. That's going to allow you to just kind of peek into the atrium and look for its papillary muscles. Its pectinate muscles. Not too much else to see. You might be able to see the fossa ovalis inside the left atrium also, but you're not going to be looking at the atrium in this kind of window, or you're going to be looking at it from behind. But similar kind of situation here where we've got blood flowing into the left atrium through the four pulmonary veins. When the left atrium is filled, the left atrium is going to contract, and there are pectinate muscles in the walls of the left atrium. Those will contract, force blood down through the left atrioventricular valve, also known as the mitral valve, down into the left ventricle. And let me jump to the next slide. Now you see the left atrium still intact here. By the way, you'd be making your U-shaped incision right in between the four pulmonary veins on the back of the left atrium. So when that contracts, it pushes down through the left atrioventricular valve. The left atrioventricular valve has a couple of alternate names. It's also called a bicuspid valve because unlike the one on the right, this valve only has two cusps. It's also called the mitral valve. And I forget what the word mitral means in Latin or Greek. So the contraction of the blood in the left atrium pushes the blood down through the mitral valve. And then left ventricle is going to fill with blood. And when it's full, it's going to contract. The increasing pressure in the left ventricle is then going to force the mitral valve to close. And jumping back to the previous slide again, the blood from the left ventricle then flows up through the aortic valve. The aortic valve looks exactly like the pulmonary valve. It's three little semicircular cusps. Blood is going to flow up through the aortic valve. By the way, notice that the left ventricle also has that distinctive trabeculae carnae pattern that we saw previously in the right ventricle. So thicker bands as compared to the pectinate muscles, and a little bit different sort of crisscrossing pattern to them. So last thing to show you is the aortic valve itself. When you do your dissection into the left ventricle, you're actually going to carry that cut right up through the aorta itself. And as you open up the left ventricle, you're also going to unfold the aorta, and you'll actually be able to see, hopefully, the three cusps of the aortic valve side by side like this, because you're going to cut right through the wall of the aorta and kind of unfold it. So normally these three cusps would all be facing towards one another, facing towards sort of a central axis. But when you open the valve and spread it out, it looks like they're lying side by side. So each cusp is just this little semicircular pocket. And there are three cusps or three leaflets. There's a right leaflet and a left leaflet. And the openings for the left and right coronary arteries are immediately superior to those leaflets. So you can actually see the orifice or the ostia of the left and right coronary arteries. Then there's a third cusp or third leaflet called posterior leaflet that doesn't have a coronary artery. So there is no little orifice above that posterior leaflet. All right, any questions? Yeah. Good question. So for Zoom people, Krista is asking if there's an advantage to having three cusps versus two cusps. It doesn't seem obvious, because you might think that three cusps would be better than two, but it's actually the bicuspid valve that is dealing with a whole lot more force, because the left ventricle is much stronger than the right ventricle. In fact, that's something I should have pointed out. I don't know how well Netter illustrated it here. Let me go way back to this one. Yeah, Netter did a pretty good job of illustrating it in this cut sectional view. The wall of the left ventricle is about 3 times as thick as the wall of the right ventricle. Very important thing to illustrate. Every one of us, and I'm going to raise my hand and admit I've drawn it wrong. I haven't always remembered to draw my left ventricle thicker than my right ventricle, at least not by a factor of 3. But that's because the right ventricle only has to pump blood to the lungs, whereas the left ventricle has to pump it everywhere else, to your head and all the way down to your feet. So you need a lot more pressure to distribute the blood to the body. So answering your question, that left atrioventricular valve is under a lot more pressure because it's resisting the pressure of the left ventricle, yet it's only got 2 cusps. So there doesn't seem to be any mechanical advantage to having 3 cusps. So who knows why the right one has 3 and the left one has 2? There's no obvious answer to that question. Oh, and let's not forget that there's an exam next Monday, right? I'll remind you again Thursday, but hopefully you all remember that. You're all aware.
Yeah.